Hi guys, it's Professor Van Cott with your Cultural Awareness lecture. You might also hear terms like cultural competency. Um, I like the term awareness because I don't think we can be completely competent about every culture that's out there, but you really should get to know some of the um, basic things about the cultures that surround you, the common cultures. So around us, it might be the Wampanoag Indians, maybe the Brazilian population, New Bedford, Fall River area, a lot of Portuguese people. Um, so anyhow, if you lived in maybe Boston, an Asian culture, so you really should just get to know the cultures that are around you. Um, and basically, the thing about culture is you really need to evaluate your own biases and understand what they are. That exercise that we did a couple lectures ago with process recordings also come in handy with checking your own cultural awareness. So what is culture? You can read the Webster Dictionary definition there, but culture is basically everything in your life. It provides a social structure for daily living, just defines how people function in society and within their families and communities, or even the institutions that they work in. Medicine, the medical healthcare arena is its own culture. And we think about the context of how that's changed over the years. It used to be that doctors were revered and whatever they said was gospel and that was it. Now we have things like WebMD and just the internet in general where people can look up information, and we view healthcare is much different, that the patient has much more of a voice in their own healthcare. So, like I said, culture is everything. Your food, your religion, your socio or economic or political status within your community, art, music, family structures, basically anything that you can think of is part of culture. So there's 7 basic elements of culture though, and I'll go through these rather quickly because you can read the slides, but you know, families, friends, social classes. Social classes are just a way that we rank people. It might be related to money or occupation or education, race. It's just how we rank people, and it's contextual based on the society that we live in. So, and then another one that I just want to touch upon in that list is interest groups. Occupation, you will all be nurses, and we're our own culture. We are a subculture of the healthcare world. So anyhow, we'll talk more about those in class, but basic organization of social status. Customs and tradition, or rules of behavior, whether they're formal or not formal in a society. So I like these pictures. We in American culture shake hands. That would be extraordinarily rude in an Asian culture. They don't touch and they don't make eye contact. So in healthcare, you know, if you have someone with a strong Asian culture and they're not looking at you, it doesn't mean that they're not paying attention, or you know, it doesn't mean anything other than it's just rude in their culture. So you need to understand that when you're providing care. Language. Language is very important for communication and passing on traditions and beliefs. So that's another part of culture. Arts and literature, we think all the way back to Plato, Aristotle, the great philosophers from BC times that valued aesthetics as very important, and they basically promote cultural pride and unity, and all things music, literature, dance are part of arts and literature. Religion, the two major differences are whether you believe in one God or more than one God. There's a list there of the major world religions. They have very distinct beliefs about death and dying, about healthcare in general, about food that you eat. So if you're in a healthcare setting, I try to shy away from questions on my tests about unique cultures. We are kind of a homogenous society on Cape Cod, so we don't necessarily know a lot about other religion and their specific cultures, but your job as a nurse, this is why I say cultural awareness over cultural competency. You need to be aware that you need to consider the possibility of different values and beliefs and customs of different cultures. So the best thing to do is just ask your patient or ask their family member, and they'll gladly fill you in so that you can accommodate their cultures. Governments. We are in a time in our country where there's a very stark divide, Republicans and Democrats. You know, that's glaring right now about how that forms our culture. Economic systems, there's just a little list there. Those play a big role in how our society functions. So race and ethnicity. I want you to be able to differentiate between race and ethnicity. Race is largely disappearing in our country. We are a melting pot. Race depends more on physical traits like skin color, hair texture, body stature, facial features, things of that sort. And you think about, you know, how our race is getting blended. I firmly believe that eventually, maybe 200 years from now, who knows, but we'll all be a brown Spanish-speaking race or maybe an Asian-speaking race across the world, because all of our traits are getting mixed. We aren't so confined to, we used to have, you know, when people first immigrated to this country, we had sections. The Irish stayed here and the Italians stayed here and Black people stayed in one place, and now we're all mixing, so we're becoming a melting pot. So race is kind of a slowly disappearing concept. Ethnicity, on the other hand, is the state of belonging to a social group that has a common national or cultural tradition. So you think about, we'll come up with some examples in class to share about certain things that are unique to certain ethnicities. It might be food, it might be music, or social structures that are unique to certain ethnicities. So cultural awareness, I talked a little bit about the difference between cultural competency. I don't believe that we can ever be completely culturally competent. There's so many different cultures out there, and you may belong to more than one culture. You know, I'm a nurse, I'm a wife and a mother, I'm a professor, so I belong to different subgroups. Cultural awareness or cultural sensitivity, there's a definition there, and you just have to recognize and value the worth of different cultures, and preserve the dignity of those individual cultures within your care. Cultural diversity. These are just kind of some definitions of different terms that you'll hear when we talk about culture. Cultural diversity. The United States is somewhat unique. We're such a large geographic area, and we have so many different nationalities, so we have a lot of cultural diversity. But if you think of most other countries in the world, France or Italy, or they're very small and they're very homogenous, somewhat more so than we are. So, you know, we experience a little bit more cultural diversity in our country, maybe than other smaller countries. So, cultural assimilation, it's just when minorities living within a dominant group lose the characteristics that made them different. They start to assimilate or acculturate to the customs and values of the dominant culture. Cultural shock is when someone comes from a different culture. You know, maybe you came from Asia and our culture is just so starkly different. Just our whole belief system, our whole value system, the way we function in society and within families and communities. Think about the shock that a person coming here may feel, and it causes a lot of discomfort and disruption in their life. And you have to be aware of that with patients, especially when they're coming into a healthcare setting and they're under the stress of being, one, sick or injured, two, in a totally foreign environment, and three, now entrenched in a completely different culture. So factors that inhibit cultural sensitivity: prejudice, stereotyping, cultural imposition. Cultural imposition is when you believe that your way is the only right way, and you expect others to go along with whatever your cultural values are. Cultural blindness is when you just don't even recognize that there may be differences. So I think, you know, as I keep saying, we do tend to stereotype. We assume that all members of a culture or ethnic group share every trait that the rest of the group, and that could be positive or negative. Negative stereotyping is racism, sexism, ageism. You know, all elderly people can't drive. All elderly people have memory deficits. You know, you think about things like that. It's just not true, and we need to really put ourselves in check when we start to think that way as healthcare providers. Don't make assumptions that just because one person from that cultural group is one way, it means that everybody is. So the specific cultural influences on healthcare, and they probably far outnumber this list, but these are just some of the influences on healthcare. Think about reactions to pain, how some cultures are extremely stoic and others are super expressive. And where do you fall on that? And how are you reacting to someone that's opposite from how you would react to that? Gender roles in some cultures, you know, they're very patriarchal. The male will completely take control of the situation, and the woman has no voice. So you're in a healthcare setting and you're trying to do teaching and you're trying to elicit information, and the husband is doing all the talking. It gets difficult. While you have to respect that, you still might need to find a workaround to let that female patient have a voice somehow. Language and communication, we talked about this in the communication lecture. When you have a different language, sometimes it gets difficult. And most of the big hospitals will have interpreters. Not only do they speak the language, but they're probably pretty aware of the different cultural issues from that group. Food and nutrition, we now have come a really long way in healthcare settings. Hospitals will offer, kosher diets, a vegetarian diet, all different diets that accommodate different cultures. So we'll go through those more in lecture. These are just a couple questions. Read through them, try to pick your answer before you scan through. Let's talk about health disparities, social determinants of health. They are glaring in this country. For instance, your sexual orientation. Gay men and lesbian women have far more health disparities than the average population. Gay men are more likely to have sexually transmitted diseases, drug and alcohol abuse, depression, suicide. Lesbians have higher rates of smoking, being overweight, alcohol abuse, and stress. So, what do you do with that information? You don't want to stereotype, yet you need to be aware that in those populations, these are things that you're going to assess for a little more intently because of your knowledge that in those populations, these are bigger issues. So a lot of times we'll see our health care will have specialized care. I know I have a friend that adopted 2 little girls from China, and she goes to Boston for her pediatrician visits because they are more in tune to different health issues that those children may face along the way. Different doses of medications that they use because they're smaller in stature and they metabolize a little differently. So they're just a little more aware of that culture. There's other things there. Obviously, we know lower income people have health disparities. There's a graph there about, check out the red bar for Black and African Americans, and we know this, we're talking about this as we're going through COVID right now. How many more minorities are dying from COVID? They don't have the same access to health care. They have more underlying issues. They have more geography. We look at geography. They tend to live in areas that are maybe more pollution. If you're going to put in a chemical plant, you're certainly not going to get it next to the executive neighborhood with the golf course. They have money to fight that. Whereas you'll probably put it next to the Section 8 housing and the projects. They don't have the resources and the voice to fight that being there. So now you're subject to more pollution, less health care, and as a result, your health disparities rise exponentially. Again, another question. I'm going by the answer fast. So we talk about culturally sensitive nursing care. And again, all I can say is that you need to be sensitive and aware that other cultures may have different values than you do. So just ask. Ask them, they'll tell you. The healthcare system is a culture within itself. We have our own customs, rules, values, our own language. Be aware of that. And nursing is actually the largest subculture of the healthcare system. We are the largest workforce in the country, so we have a pretty strong culture. And I'm sure by this point in the semester you're learning very quickly about our own culture. We have our own professional expectations. And the culture, the profession of nursing has worked very hard to elevate the culture of nursing from being the handmaids of doctors to its own valid professional vocation. So guidelines for providing culturally sensitive nursing care. First of all, check yourself. You need to know and understand what your beliefs are. Do you have specific beliefs of death and dying? That's fine. I certainly do. However, check them at the door. Whatever is important to the patient and their family is how you're going to act and react in the healthcare setting. Know that you have your values, they have theirs, and you need to be sensitive and provide culturally competent care. Develop the cultural knowledge. Know the populations that are in the area that you're working in. It may be, certain populations in a geographic location that you need to learn about. It may be, based on ethnicity, based on socioeconomics. If you work in a lower income area, you need to understand some of the issues that face those folks. Not having money to buy prescriptions or not being able to take time off from work because they don't have sick time to spare. So, respect all those things. The family rules, you may not agree, but you need to respect them. So you can't expect people to change because it's different from you, because you don't agree with it. Avoid mandating change, and seek cultural assistance. Ask someone. If you're not comfortable asking the patient, or you think they're not comfortable telling you, ask a colleague that's from the same. Look it up on the internet. Whatever you need to do, but you should seek out the information. Another question. We can't leave culture without talking about Madeline Leninger. She is one of our nursing grand theorists who believes that, in her words, quote, culture is the broadest, most comprehensive, holistic, and universal feature of human beings. She says that care is embedded in culture. It is essential to care. So she has a whole massive theory. She's got multiple doctorates. She's got many, many, many publications. She's a very prolific writer. One of our big theorists in nursing, who believes that culture is basically the crux of all care. So just touching on her. It won't be on any test, but know this for when you all go on for your BSN. It'll come in handy. So remember the nursing process: assess, diagnose. So you've assessed the culture, you've asked the patient, you've noticed the dynamics in care. These are some nursing diagnoses that might come from your assessment. They speak some other language. I don't understand a word they're saying. So we have impaired verbal communication. Non-compliance, you can't, you need to address that. So maybe they're Jehovah's Witness and they don't believe in medical care. Well, are they of consenting age? We'll get into this stuff when we do the legal and ethical lecture. So those are just some examples of what you might see as nursing diagnoses. So again, care plan: assess, diagnose, plan, implement, evaluate. We are going to do this case study in class, so read through it. It's a couple pages long. And that's it. Just read through it. Leave the rest for class. We're gonna separate into groups and write some care plans based on this. This is a really neat video that I'm gonna go by. Okay, I lost my spot. I went through the went by that video that you're gonna watch. Those videos won't play within another video, so you do have the PowerPoints posted to Moodle without the voiceover. That video is just meant to show you how deep-seated our stereotypes and prejudices are. It happened to be on the news the night that I was writing this presentation originally, and it just struck a chord with me because it's so striking how we just don't even realize it sometimes. So your job as a nurse is to realize what your beliefs and thoughts are. So on to spirituality. So spirituality, faith, and religion, there's some definitions of the difference between them. Religion, you have more of a grasp on that, but spirituality doesn't necessarily mean religion. It can include religion, but it doesn't have to. It is impossible for nurses to have a knowledge of all religions. They are countless. So ask your patient, ask a colleague, whatever you need to do. So spiritual health, in order for us to provide competent spiritual health, we need to accept the beliefs and experiences of other people. So, you know, someone has some belief that differs from you. You know, some people think if I die, I'm going to heaven, I'm going to a greater place. They're not afraid of it. Other people are super fearful of death. Someone might believe they're going to be reincarnated, and if they've done good things on the earth, they're coming back as some higher being. If they didn't, they're coming back as a lowly creature. So, you know, you just have to realize what your own values are about spirituality and religion. And it's okay to incorporate that into your care as long as you're cognizant of not forcing your beliefs onto someone else, your patient or their family. Spirituality is extremely unique to each individual. So even if I'm Catholic, the next Catholic might view their religion a little differently. Again, spirituality doesn't need to include religious practice. So spiritual distress can result from acute or chronic illness, terminal illness, near-death experiences. It can a healthcare event can rock someone's spiritual world. It really shakes their belief system to come upon a serious illness or accident. So it might change their beliefs, it might strengthen their beliefs, and they struggle with that. They're in distress. Another question. So a good way to think about assessing spiritual health is this HOPE acronym, and you guys can read through that. So you really want to look into what gives your patient strength and comfort and meaning, peace. Is it, connections, their family, their friends, their work, what gives them hope and meaning? It can be, snow falling, you never know. The O is for organized religion. So most facilities, hospitals, long-term care, rehab settings will have some sort of chaplain that comes through, and they're usually multi-denominational. They will recognize, and they're well versed on different religions, and they are more about spirituality than the religion per se. But it's very important that you observe that person's need to maintain, practice their religion, and try to structure your care around that. Also, their spirituality. So the only caveat to that is, say their spirituality involves them playing drums for 2 hours at midnight every Saturday. If it's going to infringe on your other patients on the unit, well, that's not really going to work, and you're going to have to find some alternative solution. Maybe they can go somewhere in the hospital where it's private and quiet and they can do this. But so that's the only thing. You really want to give people the best you can. Maybe they can videotape it and listen to it with headphones, or you really have to work with people to give them what they need spiritually. And then we think about you're going to assess the effects on medical care and end-of-life issues. Again, death and dying is a huge one. I'd actually love to teach that lecture because people have such differing opinions on that. And we'll talk a little bit about that in class. So spirituality, here's just some questions and approaches. It's a table right from your book. You can read through those. And some nursing diagnoses related to spirituality. So there is a care plan for Mr. Gargan on pages 1812 to 1814 in your textbook. Read through that. We'll talk more about that in class if we have time. It might spill over into lab or lecture a little bit. Lab or clinical. But take a peek at that. Just breeze through it. Don't read it real intently. You don't need to memorize information from it. Just get a gist of it. So we went through assess, diagnose, plan. Now we're implementing. This is a nice little schematic of how you implement spiritual care. And remember your interdisciplinary team. So that blue circle, the second icon, you see it's not just the nurse, the physician, the social worker, the chaplain. I talked about having a multi-denominational spiritual person on board. So all those people have their role in the process. But typically, as the nurse, you're the front line. You're the one that spends the most time with the patient. You're the one that does the initial assessment. So you need to pull in those people as necessary. That's part of your role. And finally, the last phase of the nursing process, evaluation. So, did you identify some spiritual belief that gives meaning and purpose to everyday life for your patient? Assess again, you reassess. This is a cyclical process, the nursing process. So are they moving towards a healthy acceptance of their situation? Maybe they have terminal cancer, and you have to do a lot of work to get to that place where hopefully before they go, they're okay. They've come to some acceptance of their situation. And then just a few other points about that. It's some patients, it's very important to get right with God kind of thing. They verbalize satisfaction with their relationship with a higher power. Think about what we said before about how it rocks their beliefs. They come in and, how could this happen to me? How could I have cancer? I've been a good person. I've donated to charities, and I do all these good things for people, and how could God do this to me? And they're angry. And they have to come around to a place where they can let go of some of those feelings that will cause detrimental effects to their health. So very important that you evaluate. So that is the end of the nursing process. Again, we will go through those case studies in small groups in class. And this one was really long. I thought this would be my shortest one. So without further ado, enjoy the rest of your day, folks. See you in lecture.